My dear colleagues, friends, ladies and gentlemen, thank you for the opportunity to participate in the International Anesthesia Research Society annual meeting. The right ventricle is considered as a neglected chamber, but in the last 2 to 3 years, there has been a great realization that the right ventricle plays an important role in the maintenance of hemodynamics. Acute right ventricle failure may complicate 20 to 30% of left ventricular assist device implantations, 10% of heart transplantations, 3 to 5% of congenital heart disease surgery and valvular heart surgery, and about 1% of routine coronary artery bypass grafting. The important fact is that the mortality associated with severe right heart failure approaches to about 50%. I'll be touching upon the pathophysiology of acute RV failure, diagnosis, medical management, and the use of mechanical circulatory support devices in patients who have right ventricular failure. This depiction shows the three-dimensional reconstruction of the RV, illustrating its complex shape in a normal subject in the panel A and in a diseased RV in the panel B. The relationship between the lung volume and the pulmonary vascular resistance is shown in this graphic representation, and it is clear that the pulmonary vascular resistance is the lowest when the lung volume is in the functional residual capacity. The interrelationship between the afterload, which is a surrogate of the arterial pressure, and the stroke volume is exhibited in this slide. The right ventricle is highly sensitive to the increase in the afterload with prompt reduction in the stroke output with increase in the afterload vis-a-vis the left ventricle, which has some amount of capability to withstand the increase in the afterload acutely because of the intrinsic homeostatic mechanisms. The interaction between the right ventricle and the pulmonary artery, which is shown here, depends upon the pressure-volume relationship when you're talking about the ventricle, and the pressure-flow relationship when you're talking about the pulmonary circulation, which in turn depends upon the heart rate, the end systolic elastance, the relaxation, diastolic stiffness when you're talking about the right ventricle, and vascular resistance, arterial compliance, and arterial elastance when we are talking about the pulmonary artery. Under steady-state conditions, the optimal ventricular efficiency is achieved if the end systolic elastance is matched by the arterial elastance. This relationship may be maintained in the early phases of pulmonary hypertension because of our right ventricular hypertrophy. But with the onset of the right ventricular failure, this relationship between the end systolic elastance and arterial elastance is reduced, and there is increase in the right ventricular end diastolic volume and pressures. The relationship between the pulmonary vascular resistance and the pulmonary compliance is reciprocal. That means that when the pulmonary vascular resistance is increased, the pulmonary arterial compliance is low, and vice versa. The right ventricular failure in principle is a hydraulic problem caused by impaired function of the pump, the valves, or the conduits on the right side. The diagnosis of right ventricle remains a major clinical challenge. We need to use physical examination, echocardiographic and invasive hemodynamic measurements to be able to diagnose right heart failure. Of interest, I would like to mention the relationship between the right atrial pressure and the pulmonary capillary wedge pressure. If this ratio is greater than 0.63, it is a herald predictive of right ventricular failure after left ventricular assist device implantation. Similarly, the pulmonary artery pulsatility index, shortened as PAPI, which is a relationship between the pulmonary artery pulse pressure and the right atrial pressure. If it is less than 1.85, this indicates the possibility of occurrence of right ventricular failure after left ventricular assist device implantation. The other modality which is recently described is the measurement of the RV pressure using a spaceport lumen of a pulmonary artery catheter. If we record the pressure in the RV using this spaceport and relate it to the right atrial pressure and the pulmonary artery pressure, it may give some insight into the nature of right ventricular function, especially with regard to the right ventricular failure. The types of right ventricular pressure waveforms obtained through the pulmonary artery spaceport catheter when placed in the when the lumen of the pulmonary spaceport is in the right ventricle, we get the tracings of the pulmonary artery pressure, which is shown as dotted lines, and the right ventricular pressure, which is shown as a continuous line. And this is the normal relationship. As the right ventricular function deteriorates, the shape of the right ventricular diastolic pressure changes, indicating the onset and deterioration of the right ventricular function. The same thing is depicted in a real life situation here. This is the relationship between the right ventricular pressure and pulmonary artery pressure, the right ventricular pressure and right atrial pressure, and the right atrial pressure and the pulmonary artery pressure. Coming to the echocardiographic and CMR evaluation of the right ventricle, we have the fractional area change, tricuspid annular plane systolic excursion, the tissue Doppler S-wave velocity, and the right ventricular global longitudinal strain on spectral tracking, late gadolinium enhancement of the right ventricular insertion points on cardiac magnetic resonance, and typical D-shaped left ventricle in patients with right ventricular failure. The American Society of Echocardiography has described the following parameters which are useful in the echocardiographic evaluation right ventricular function in patients who have pulmonary arterial hypertension. These are TAPSE, that is the tricuspid annular plane systolic excursion, right atrial area, the eccentricity index, right ventricular longitudinal strain, and right ventricular fractional area change. The effect of volume infusion on the right ventricular function in right ventricular heart failure is shown here. With excessive infusion of fluids, the septum is, interventricular septum is shifted to the left, leading to decreased left ventricular filling and decrease in the cardiac output. And if this is treated by diuretics and unloading the right ventricle, there is improvement in the left ventricular filling pressures and cardiac output. These are some of the echocardiographic pictures of right ventricular dysfunction in patients who have pulmonary hypertension as a result of chronic thromboembolic disease process. This is a patient with mitral stenosis who has right ventricular dysfunction, gross enlargement of the right atrium, and the 3D echocardiography reconstruction of the right ventricle showing normal systolic function on the right side vis-a-vis the impaired right ventricular function on the right side. Coming to the therapeutic approaches, the treatment of right ventricular failure includes control of the triggering factors or precipitating factors, for example, pulmonary thromboembolism, optimization of the fluid status, removal of excess fluids using diuretics or hemofiltration, control of the right ventricular afterload by using pulmonary vasodilators, optimization of cardiac output using inotropes such as dobutamine and milrinone, and maintaining the coronary perfusion to the right ventricle using vasopressors such as norepinephrine and vasopressin. If the conservative measures do not lead to improvement in the clinical condition, we might have to consider extracorporeal membrane oxygenation Or if the prognosis is not really good, we just have to do the supportive care. These are the inotropes and vasopressors which are useful in patients who have right ventricular failure: dobutamine, dopamine, milrinone, levosimendan, epinephrine, norepinephrine, and vasopressin. Coming to the mechanical support, we have the durable devices and percutaneous acute mechanical circulatory assist devices. In the acute devices, we have the right ventricular, the devices which directly bypass the right ventricle or indirectly bypass the right ventricle. And the pictorial depiction is shown here. In acute RV failure, for directly bypassing the right ventricle, we have the impella for the right ventricle, which is called impella RP, which is introduced from the femoral vein through the right ventricle into the pulmonary artery. This device, using the axial principle, when activated, sucks blood from the right ventricle and puts it into the pulmonary artery, thus causing reduction in the right ventricular pressure and improving the cardiac output. In the tandem heart, the venous blood is taken from the right atrium and is passed through the pump into the pulmonary artery. And you have Protec Devo device where a double lumen cannula, one lumen opening the pulmonary artery, the other opening into the right atrium. The right atrial blood is taken and it is passed through the pump into the pulmonary artery, which can be used either with an oxygenator or without an oxygenator, depending upon the pulmonary function. Lastly, we have a veno-arterial ECMO, that is, the venous blood is taken from the vena cava or the right atrium and then oxygenated and put onto the left side of the circulation, that is the systemic arterial circulation after oxygenation, thus leading to indirect bypass of the right ventricle, giving time for the right ventricle to recover. This is a animated picture of insertion of the impella RP through the inferior vena cava, through the tricuspid valve, right ventricle, across the pulmonary artery into the pulmonary, across the pulmonary valve into the pulmonary artery. And this is shown to improve the right ventricular function for a short, as a temporary circulatory as a device in patients who have a body surface area of greater than 1.5 square meters, which can be used in patients who have acute heart failure, acute right ventricular failure following left ventricular assist device implantation, right-sided myocardial infarction, right heart failure after heart transplantation, or any other form of open heart surgery. These are percutaneous in biventricular acute mechanical circulatory support device configurations, which are shown here. This is combined tandem heart with impella. This is impella RP with impella is a left ventricular support device. And this is combined impella CPA and RP. To conclude my talk, the right ventricular failure remains a major cause of morbidity and mortality. Understanding pathophysiology of RV failure is important in managing these patients. Initial management should focus on determining the cause of RV failure and reversing or treating the cause. The optimization of preload, afterload, and contractility take precedence in management of these patients. Short-acting pulmonary vasodilators, judicious use of vasopressors and inotropes are useful in improving the right ventricular perfusion and contractility. Extracorporeal life support techniques may be used to restore circulatory support when other measures fail. With this, I would like to thank the International Research Society of Anesthesiology and the audience for your patient listening. If there are any questions, I'll be happy to handle them. And thank you so much for the invitation.
Thank you so much for this opportunity to discuss with you the challenges of cardiac anesthesia in a low-resource country a Ugandan experience. I am Cornelius Sedagire, and I'm a cardiac anesthesiologist and intensivist at the Uganda Heart Institute, as well as a lecturer at Makerere University in Uganda. I'm also one of the editors of Open Critical Care, and I have no conflict of interest to declare for this particular talk. Uganda is located in East Africa, directly on the equator. It's a small country about the size of Minnesota in the US. Like Winston Churchill said, it is the Pearl of Africa, and therefore, if you're ever out here, make sure to enjoy the beautiful scenery of the nature that you'll find here. Uganda's capital city is Kampala, and this is where most of the tertiary hospitals are found, and this is where I also work. If you look at the demographics, it's a pretty young country with more than 50% of the population under 15, and that compared to the US, that is 38, can easily tell you the kind of the epidemiology of disease that is likely to be found, especially heart disease in this country. The Uganda Heart Institute exists within the complex of the Mulago Specialized Referral Hospital. And if this is the front part of the hospital, the Uganda Heart Institute is located at the back of the hospital. And this is where most of the cardiac services within the hospital are provided. We have one catheterization lab, and in this lab has existed for about 10 years now. And in this lab, we provide procedures for both adults and children. And we have done about 5,000 procedures in the last 10 years, with the booming growth within the last 2 to 3 years in terms of the procedures we are able to do. And those would include coronary angiograms and BMVs, pacemaker insertions, and what is still quite rare is electrophysiological studies. And then for congenital heart diseases, we do perform PDA device closures, BPVs, and Rushkins, as well as diagnostic cuts. What we don't do a lot is ASDs and VSD closures. We have one cardiovascular OR, and again, it's been around for about 10 years, but I have to mention that open heart surgeries have existed and have been done for much longer than 10 years. So this particular OR is celebrating its 10th anniversary this year. We have conducted nearly 1,000 open heart surgeries over that period of time, and we do both adult and pediatric surgeries. Most of the surgeries we do, especially for acquired heart disease, are valve surgeries, mostly for rheumatic heart disease, and because of the nature of the disease and the time of presentation, we mostly do replacements. We also perform vascular surgeries, like abdominal aortic aneurysm grafts, as well as cabbages and aortic aneurysm, thoracic aortic aneurysm repairs, although the latter two are not commonly done here. For congenital heart disease, we do perform ASD and VSDs, and perhaps the more complex ones that we do are TAP PVR and tetralogy of Fallot. We do some single ventricle repairs like common artery bands, but we do a lot more PDA ligations and coarctation repairs. We do have one ICU that provides services mostly to the surgical patients. It's a 3-bed ICU, and there's an extra bed that is provided for patients from the coronary care unit who may require invasive respiratory support. And so this ICU exists because of the fundamental renovations that existed within the Mulago Specialized Hospital. So this ICU allowed us to continue our services, but we hope to soon move back to a 15-bed ICU within the Mulago National Specialized Hospital. The WHO does recommend that for every 2 million people, at least one cardiac center should exist that performs 200 to 500 operations annually. If we look at the population of Uganda that has 45 million people, you'll find only one cardiac center that is performing approximately 100 open heart surgeries annually and about 200 catheterization procedures annually. And of course, this highlights a very limited access to cardiac services. And because of that, there are a lot of limitations that are bestowed upon us. a picture is worth 1,000 words, and this is really the department of cardiac anesthesia and critical care in a nutshell. And this is a photo that does not include 3 fellows that are undergoing training and hopefully will be back soon to be part of us. However, the team that you see here conducts services from the OR to the cath lab to the ICU, and of course that bears a huge burden on what we can do. The WFSA does recommend at least 4 anesthesiologists per 100,000 people, but in Uganda we have 1 anesthesiologist for 500,000 people, and so the limitation in terms of provision of good quality care is limited. And because of the limitations in the human resource within the department, with having so many sites to cover, there's going to be concerns with long working hours. And of course, that leads to a lot of stress and burnout. But perhaps one of the biggest challenges is the competency decay related to performance of very few cases, fairly simple cases with no significant challenge in terms of complexity. And while most of us trained in cardiac centers with very high-end cardiac programs and mastered multiple skills and experiences, this kind of puts us back in terms of the capacity that the team can do. And so it's not all bad. We get supported a lot by the rest of the team, one of whom is the nurse who assists the anesthesia team to prepare for surgeries, but also the rest of the teams like cardiologists who help us with the TEEs, where the cardiac anesthesiologists may not be very competent in doing TEEs, but where they are competent, they still help out in the sense that they allow us to focus on the rest of the care for the patient and not just the TEE. In terms of resources regarding provision of safe anesthesia for patients, we do have all the equipment and nothing is lacking. However, the consumables tend to be quite expensive and very limited in stock, and this being the only cardiac center providing a broad range of services, the market forces do not allow the cost of the consumables to reduce, and so that becomes a challenge. However, one of the biggest challenges is blood, and this has led to cancellation of many cases. And so in our setting where the blood transfusion services are quite limited, for performance of cardiac surgery of any kind is riddled with a lot of challenges regarding transfusion. In Uganda, the typical cardiac patient is going to be a child, based on the median age of the country, and so the disease process is going to be more to do with congenital heart diseases or rheumatic heart disease. However, the child you're more likely going to find may look more like this, a 1.5-year-old child who, however, is as small as an infant. And these are some of the challenges that are related to the patients. They're coming from a low socioeconomic status, and that leads to malnutrition, poor access to care that leads them to come in fairly older for the surgery than normally would be needed. And then because of that, they tend to be poorly optimized pre-surgical, and so the concerns regarding provision of anesthesia tend to start to arise. But also the challenge that these children experience include infections, especially respiratory tract infections and malaria. And so in most instances, we have to decide whether we should cancel the cases or we proceed. However, we have to understand that due to extremely long operating lists of more than 300 patients, canceling one case leads to a huge delay to provision of services for the remaining number of patients who actually need these surgeries. And that means that we have to appropriately select who is going to have the surgery based on their clinical status, but also based on the resources that we have. And this can be extremely challenging in itself. So while it's difficult to protocolize patient selection, we do end up using a multidisciplinary team approach to make a decision on who is going to have the surgery based on the complexity and the resources needed. Being part of a health infrastructure system that is not adequate in itself means provision of cardiac anesthesia services is going to be very limited. And so there are a lot of inefficiencies that will exist. Lack of patient databases is also a big concern here, because then we cannot really trend the care that we've given over time. And then limitation in provision of rehabilitation services and palliative care services does exist, especially in a situation where some patients need a lot more help to recover. So in summary, we do have patient-related challenges with very long waiting lists and poor preoperative status that affect the way we deliver the anesthetics. And then there are, of course, space-related challenges. With the current 3-bed ICU, we cannot do so many cases. But even if we move into the 15-bed ICU, the space-related challenge is going to remain, because we have 45 million Ugandans who may at any one point need care in the cardiac institute. And then, of course, we have staff-related challenges. We just a handful of anesthesiologists running the OR, the ICU, and the cath lab. And then, of course, the supplies that are quite costly, but blood being a major scarce resource leads to a lot of limitation in terms of what we can do. And then poorly structured healthcare system that does not fully support. However, hope springs eternal. And so we've come a long distance with great leadership within the Institute and a lot of government support and multiple partners, both local and international. We have made huge strides in the number of cases we are doing, the complexity we are doing, and the survival is a lot higher than it used to be back then. I want to say thank you for listening. Asante sana.
Ladies and gentlemen, it's a pleasure for me to present my talk about the most important anesthetic considerations in transcatheter valve replacement. Here are my conflicts of interest. And in the next 15 minutes, I will give you an overview about the most important clinical implications, which are not addressed only to the anesthesiologist, but also to the whole heart team. And according to recently published expert consensus conferences, a multidisciplinary team is recommended to ensure maximal patient safety. Therefore, it is of particular importance that the anesthesiologist of the heart team needs extensive knowledge and experience in cardiac anesthesia, as well as transthoracic and transesophageal echocardiography. Since 2002, Alain Cribier was the first. Transcatheter aortic valve replacement has become an established, less invasive alternative to surgical valve replacement in high-risk patients. Meanwhile, more than 50,000 TAVI procedures have been performed worldwide, and due to the demographic change, there still will be a dramatic increase expected and an expansion of indications. Aortic stenosis has a high prevalence in elderly patients over 70 years. Severe stenosis is defined as an open area below 1 centimeter square, more than 4 meters per second velocity, and a gradient over 40. The symptoms vary from asymptomatic short breath, syncope, or signs of heart failure. It is important to know that without treatment, the mortality is high. 75% die within 3 years after the first symptoms. Due to several multi-center controlled trials in the last decade, clear definitions were defined by international societies, such as the report of the American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guidelines regarding patients with valvular heart disease. They gave clear indications for patients below 65 years for the surgical approach. However, patients over 65 up to 80 years should receive the TAVI procedure if there are no anatomical contraindications. And over 80 years, TAVI procedure is indicated in mostly all patients. So what you see here is that the trend for TAVI is for more younger and fitter patients. However, The transcatheter versus the surgical approach is still under discussion through the surgical and interventional societies. And since 2021, Partner 3 trial showed the 2-year outcome results in elderly patients, and here the outcome measures death and disabled stroke in surgical patients after 2 years was not inferior compared to TAVI. Therefore, this discussion is still going on, and we see it in the European guidelines. And you see it in the next slide. Therefore, the EACT and ESC guidelines 2021 give a clear and consistent recommendation regarding the age. All patients below 75 years should be treated surgical. In case of any anatomic contraindications, such as reoperation, radiotherapy, for example, or porcelain aorta, the patients should be treated by TAVI. And all patients over 75 years should be treated with a TAVI procedure. There are different surgical and transcatheter accesses. The transfemoral access is the most often procedure, nearly by 80%. However, the subclavian or axillary access is increasing within the last years. Accordingly to recent published expert consensus recommendations, TAVI should ideally be performed in a dedicated hybrid room that combines the advantages of a catheterization laboratory with high-resolution imaging and with those of an operating room. This means sterile environment, laminar airflow, anesthesia workplace, echocardiographic facilities, possibility of cardiopulmonary bypass, and the possibility for conversion to open heart surgery. In the next slides, I would like to present you the important steps, key steps of the TAVI procedure of a self-expanding Evolut TAVI and a balloon expanding SAPIEN. What you see here is a placement of the vascular sheath and femoral and artery and vein, and be aware of typical complications such as bleeding, rupture, dissection, or ischemia. And at this time, a temporary transvenous pacemaker is inserted via the vena jugularis vein or the vena femoralis, and you have often the risk of ventricular perforation by the pacemaker. And at this time, heparin is administered to achieve an activating clotting time of 200 seconds. In this slide, you see firstly on the left side the retrograde placement of the pictate catheter in the non-coronary sinus, and this is a landmark to depict the levels of aortic annulus. And you see the guide wire across the aortic valve. And now in the next picture, you see the rapid pacing balloon aortic valvuloplasty here with the ECG. And it's important that you have adequate filling pressures and adequate mean arterial pressure, because hypotension might be associated with the hemodynamic deterioration, cardiac arrest during the rapid ventricular pacing. So the next steps are the valve positioning and the deployment on this slide. And this is a very critical period because calcific embolism, coronary flow obstruction, aortic dissection, or even rupture of the aortic annulus can occur as possible complications. So now we are in the period of recovery and assessment of the regular valve position and function. And vascular closure device and the removal of delivery sheet is now followed by the crossover iliofemoral angiogram to assess hemostasis. In this period, you give the protamine to antagonize heparin, and possible complications are bleeding, pseudoaneurysma, and ischemia. in this situation. In addition, it is very important that you have a TTE control to exclude a paravalvular leakage, aortic valve mean gradient determination, and to exclude a pericardial effusion. Here I would like to demonstrate you the balloon expandable Sapien Ultra. Also here you see the device for the valve, and here at the end the aortography. So with the exact positioning in the aortic annulus. And in this next slide, I would like to show you a really rare serious complication during this TAVI procedure. The TAVI dislocated in the LVOT and repositioned in the opposite position. This is the reason for the opposite pressure curve on the monitor, and emergency cardiac surgery resolved the problem, and the patient was recovered at restitutio ad integrum. So I demonstrated the key steps of the procedure and the possible complications that can occur in this high-risk patient collective. And regarding patient safety, it's important that we have several implications for the anesthesia management in these high-risk, fragile patient collective. And this means prevention of postoperative complications. And we have dependent steps, and this includes risk evaluation, prophylaxis, monitoring, and intervention. And it is regarding risk evaluation important to know the physiological changes in older age. And this means not only the neurological changes like dementia, depression, or even higher risk for postoperative delirium. This means also cardiovascular changes with respect to a reduced sympathetic response and diastolic dysfunction, which has several implications regarding a blood pressure lability or intraoperative hypotension episodes and cardiac dysfunction. But also regarding the pulmonary side, the kidney side, is important to know that an altered drug metabolism and a reduced renal mass are associated with a reduced drug clearance and often also with an acute kidney injury after the procedure. Therefore, it is important to recognize organ dysfunction with screening biomarkers regarding cardiovascular comorbidities, hypertension, atrial flutter, coronary artery disease or peripheral artery disease, pulmonary hypertension, renal insufficiency, and even anemia. There's another important point that is a clinical frailty scale. You can go like an eyeball system from very fit, well, managing well, to vulnerable, mildly frail, and moderately frail. And as far as we know, frailty is associated with delirium and mortality after TAVI implantation, and it has more independent prediction compared to the Euroscore. And this is the reason why the guidelines include a perioperative assessment for risk stratification in these high-risk patient collective. I would like to present you what we are doing in our risk stratification. We call it ERSAS group. It's an early risk stratification and strategy. And we are looking for the resources of the patients like cognition, psychological status, muscle strength, physical activity, nutrition, and organ dysfunction to decide a patient individualized pathway. And this, for example, is our HDZ frailty and delirium management team consistent of nurses and doctors and also students. And this team was part of the HDZ core team, consisted of all disciplines in our hospital and also the nurse, including the nurse department, the anesthesia, the intensive care unit, the operating rooms, but also the physiotherapy, the pharmacy, and the IT documentation, all together called the HDZ delirium management to prevent cognitive dysfunction after surgery or intervention. And this is also part of a multi-component program in elderly patients, and we are covering from the anesthesia side the project 1, the risk stratification, screening and the pathway, but we have also the non-pharmacological prevention from the nurse side and the psychology project 3 and the physiotherapy for the rehabilitation, all with the same goal, early recovery after surgery or intervention. So here on this next slide, you see our preoperative frailty assessment and the batteries that we perform with the patients, delirium screening, EEG monitoring, delta scan, the functional status, hand grip strength, balance test, and the nutritional status. And we are doing post-anesthesia visits until the day post-op 3. And this includes delirium screening, EEG monitoring, and the clock drawing test. And this is just to show you that we have real frail patients, the major part, and these are 2 examples of clock drawing tests. And here you see the geriatric assessment, several results in our hospital, and you see there are 3 factors that are severely impaired. This is mobility, nutrition, and worry. And here I present you our standard operating procedure for TAVI transfemoral, which is conscious sedation with propofol, dexmedetomidine, and a small sulfentanyl bolus. In case of respiratory insufficiency or severe heart failure, several patients are undergo the procedure with general anesthesia. All patients are inducted with etomidate to ensure maximal hemodynamic stability. Regarding the monitoring, all patients receive EEG monitoring, an arterial line, a central venous catheter, and all punctures are ultrasound guided, and an external Defi pads, a 5-lead ECG, urine output, and temperature management. So here you see the results of our TAVI patients and the post-anesthesia visits until day 3. We have a very low rate of delirium positive patients from 13%. And a low rate of PONF and very low pain intensity scores. Taken together, our concept includes early risk stratification, optimizing organ dysfunction, and screening and monitoring. And the perspectives are patient empowerment with a nurse concept for frail patients, and I think the prehabilitation program to optimize the 3 important factors: worry, nutrition, and exercise. Thank you very much for your attention.
Okay, so please everybody switches now into the Zoom mode so that we can commence with our discussion. First of all, I would really and truly like to thank all speakers, Dr. von Dossow, Cornelius, and Dr. Kanchi, who I don't think is available now for the discussion. That is unfortunate, but we couldn't get a hold of him during this hour. I am grateful that you provided us with that information from Asia into Africa, into Europe, because this is truly, and in the best word sense, the heart of the WFSA, who was fortunate to be able to join the IARS annual meeting. We're always keen as a WFSA to have a joint meeting with either ASA and or the IARS, displaying a nice mix between cutting edge medicine and also medicine displayed from low and middle income countries. It was just almost touching, Cornelius, what you presented to us. If you, as us, you live in a almost no limitation resource situation, and then be able to perceive the conditions that you're exposed to, the small team of cardiac anesthesiologists and nurses in ICU, 3 beds. I must say, I'm really impressed, not to say I'm touched. Well, this is a discussion. Please use the chat if you wish so. And I'd like to start with Cornelius. I have a question. Why, you said there is support from your country. There's national support. The government is strongly, immense. You said it's an immense support. So why is it that there is a shortage of anesthesiologists? Does the same situation apply for the surgical specialties or internal medicine? Is that a general habit in your country, or is it an anesthesiology only issue?
Thank you very much for that question, Christian. I think if I can put it in context, I think up to about 2008, Uganda had probably less than 15 anesthesiologists. I think the real training started in 1990, and during that time, it was quite difficult to get anyone to join the specialty training in anesthesia. And so it was quite a challenge until 2008 when there was a drive from within the country and also from partners through international collaborations that allowed us to have a growth in number of anesthesiologists. And over the last, I would say, maybe from 2008 up to now, over about 12 years, we've seen a huge surge in number of anesthesiologists from less than 15. Now we are approximately coming to about 75 anesthesiologists, and we are having a huge number of residents coming in at this time. So we hope that that number will continue to increase. The other disciplines that one would consider the main or the traditional disciplines like internal medicine have been around since the country had independence. And so they had a chance to actually grow significantly and have fairly big numbers: pediatrics, surgery, obstetrics, and internal medicine have enjoyed a lot of that. But the times have shifted in the sense that the government has provided a lot of support in terms of scholarships for training in anesthesia. And that allowed a lot of residents to actually come in, and also it increased the popularity of the course to the extent that now we're having to screen out who to take in and who not to take in, which has never happened before. So I think to an extent, the argument is there's been a lot of support, and it has not been withdrawn at all. And I would say, because of the COVID-19 pandemic, and because anesthesiologists do a lot of work in the ICU here still, the government is still pushing to have a lot more of them be trained, but also opening up other avenues for having nurse anesthetists who have a lot more training than anesthetic officers has been done. So I think there's a huge drive to make things better. Thank you.
Thank you, Cornelius. Please wave your hand. I could see so in case you have questions from the group that I can see here, that is among the discussants. Dr. von Dossow, that's pretty much the opposite, I guess, where you work in the largest ever heart center in this country, the Federal Republic of Germany. And I wonder what your projection is as to our role in minimally invasive transcatheter-based interventions. As when we started, you in Großhadern, I guess, or Berlin, and myself here in Mainz about 10 years ago, this is an active place ourselves, we were full-blown with pulmonary artery catheters and the whole thing. And we were slowly but surely, with maturing, with getting more experience with these cases, retracting ourselves from invasiveness. And you just said in your last 2 minutes of your talk, you said it's more or less, it's awake sedation concepts and so forth. Are you projecting that maybe in 5 to 10 years from now, anesthesiology is no more required as a specialty during transcatheter replacements, like we've experienced with endoscopy? When propofol started, every endoscopy in internal medicine was performed in the presence of an anesthesiologist. That's gone pretty much. So are we facing the same thing?
Well, thank you for this question, because I think the trend is going to be more or less invasive, not only in the interventional side, but also from the anesthesia side. And I think it's different in America, because there the trend is already to do it in local anesthesia, to talk with the patient, and to have less invasive arterial or central venous punctions. However, I think in Europe or in Germany, it's a little bit different, because the patient collectives are very old. And I think the discussion is not that even if the procedure is less invasive, that means that you have take care less on the patients regarding monitoring. I think indeed regarding arterial line, the central venous line, I think this might be discussable if you need it or not. But however, the arterial line regarding hypertension episodes, I think this is underestimated. And also regarding the postoperative recovery of these patients, I think even just to answer your question, if we are not there anymore, I don't think so, because I think it's important that the anesthesiologist is good prepared and is experienced in cardiac anesthesia. And regarding patient safety, on my opinion, it's important that we stay there and we take care of these high-risk patients.
Thank you very much. Miko Zuckner has a question to you, Dr. von Dossow, and he's asking, in patients that undergo a transapical access, whether you routinely use local blocks such as a PV or ESP blocks. What is your position to that? Thank you for the question, Miko.
Yeah, for the transapical access, we since several months, we started with the paravertebral and with the ESP blocks after the procedure. So prior to, we extubate all patients after the transapical TAVI procedure in the OR, but prior extubation, we use a ESP block or a paravertebral block for this procedure, because the pain intensity is much higher than we expected. I think there's also coming lots of literature or papers now that have been published for these thoracic access.
Cornelius, I have a question to you. We've talked about shortages in manpower and qualification, not really people not wanting or not willing to work, but training and education and so forth. What about the technical side of your work? The OR that you displayed to us, the 10th anniversary OR, was very impressive and not different from the environment that we work in. But I mean, in terms of catheters and drug availability, you've also talked about the shortage in transfusion material and so forth. So could you make us learn and understand and get a view and picture from your day-to-day practice as far as the availability of these resources is concerned?
Yeah, I think the one of the biggest challenges has been having the consumables and the drugs to the extent that sometimes we depending on the time of the year, we may actually run out of inotropes that we normally use in cardiac surgery, and that means that we may not be able to perform some cases. However, because of the sometimes the few number of cases, we end up having a lot of stock, and so that we end up into the risk of expiry of some of the drugs that we have, and that becomes a bit of a problem, because then we have to kind of increase the number of cases we are actually doing. And so we what we tend to do in most instances is to do in-house, we call them camps, where we almost do cases every day. Normally we perform about 2 to 3 open heart surgeries per week. In a camp scenario, we have to do probably up to 7 to 10 per week. And so that increases a huge load on the entire team, but it allows us to avoid expiry of some of the supplies. But also the other challenge comes on the side of the perfusionists, who sometimes run out of oxygenators for one reason or another. The stocks do not come in as well as we may be using them. So over time, we've learned to sort of adapt in terms of how much stock we expect to run, maybe for about 3 months, and then using that we would estimate that maybe over a year we shall need this amount. So regarding and I think I would say maybe in the last couple of years we've not had a lot of stock out because of the improved planning. The issue became blood, especially those with very rare blood groups, and that has led to a lot of cancellation. Just this week we had to cancel an AB positive patient because we did not have FFPs that were appropriate for them at the time. So it was a bit of a challenge in that regard. So it's continued to happen, but we hope that at some point we should be able to improve that.
Thank you very much. So Cornelius, from a WFSA point of view, and also on behalf of Adrian Gelt, the president of the WFSA, who is actually planning to join here, but is now busy in London for the council meeting. Is there anything that you, like right off the bat, would be could wish for you, your team, your institution, that the WFSA could support with? Anything specific? Just, this is a learning session here, so I'd like to learn.
Yeah.
If anybody could be by your side in whatever capacity.
Yeah, I think the biggest driver right now, and this is the vision of the institute, is the institute is mostly driven to increasing the capacity of the human resource, and because the leader that we have, who is the executive director, believes in empowering the individuals who are working within the institute to be able to advocate for everything that is required to perform the procedures and reduce people from going outside the country to get these services. And so I think one of the ways the WFSA could assist or support cardiac programs, especially on the side of cardiac anesthesiologists, is to provide opportunities to have an interaction with various cardiac anesthesiologists abroad in more advanced programs, but also in scenarios where we have visiting teams coming in to work with us, or we actually see just what we call shadowing in other centers where we have the opportunity to see what people are doing differently, to allow growth. I think that has been quite helpful. Okay. And I think it would be great to have WFSA join in and help that aspect of improving the capacity.
Very clear, and I hear you loud and clear. And thank you so much, Cornelius. For now, it's Vera von Dossow and certainly myself, who I'm sure you can be in touch with for shadowing, etc. And I will take your message and your request to the council meeting for next week for the WFSA, and we'll get back to you. It's 45 by the minute. We're right on time. Again, for the three that displayed this wonderful session, thank you very much again on behalf of the IARS and the WFSA, and take care and further enjoy the IARS meeting. Vielen Dank, bye-bye, and auf Wiedersehen.
Thank you.
Bye-bye.
Ciao, thank you.
Bye.
And thank you to the audience, of course. Thank you.
Bye-bye.